AP knee medial oblique is the same as an AP knee. 3 to 5 degrees caudad for a thin patient, 0 for a medium patient, and 3 to 5 cephalic for a thicker patient. Again, we're gonna remain at 0 degree angulation because homeboy again is an average patient. We're gonna keep it at 65 and 5 because we really haven't changed very much, and he's shielded, so it's time to take the exposure. Don't move. Now for the lateral knee. You have the patient roll over onto his or her affected side. You want the affected leg in front and the unaffected leg behind. Oh, and we are taking the image plates out after every exposure. I'm leaving it in here for the purpose of the video, for brevity. Okay, so patient's laying on the affected side. You don't want any rotation of the pelvis. You want the affected knee forward and the other limb behind it. With the affected knee, you want 20 to 30 degrees flexion. If the patient can handle it, this guy can. You do the 20 to 30 degrees flexion to show maximum volume of the joint cavity. Now for this, you angle the central ray 5 to 7 degrees cephalic, and this prevents the joint space from being obscured by the magnified image of the medial femoral condyle. So there's roughly about 6 right there. Stop filming for a second. And the central ray also enters 1 inch distal to the medial epicondyle of the knee. Again, my technique is going to remain the same, 65 and 5, because the lateral width of the knee is roughly the same as the AP width of the knee. So I'm going to remain at 65 and 5. I'd be better about correctly shielding a patient in the actual clinical, but this guy's hard to keep in position, so this is going to have to do. Okay. Ready to take the exposure, don't move. Okay, this is for the tangential projection of the knee, the set-gast method, also known as the sunrise. The SID is 40 to 48 inches. The patient can be either supine or prone, preferably prone. The plate we have in goes crosswise. And the film goes in crosswise, and again, the patient is supine or prone, preferably prone. So we have our patient prone. The position of the part, you flex the knee slowly as much as possible or until patella is perpendicular to the IR. If need be, you can loop a string or bandage around the patient's ankle or foot and have the patient hold it to maintain the position. This guy's a little out of commission, so we're gonna improvise. this is vertical. The long axis of the leg you want to be vertical. And again, the IR is transverse under the knee, and you center it to the joint space between the patella and the femoral condyles. Oh, this isn't going to work. The central ray will be perpendicular to the joint space between the patella and the femoral condyles when the joint is perpendicular. And you want the tube angle to be about 15 to 20 degrees. We're going to pretend this patient's knee is vertical, because there's just the two of us. The central ray should be entering right about here. I've set my technique to 60 at 32 because we're shooting for the patella, not the rest of the knee. Again, going to shield the patient as much as possible. And time to take the exposure. Don't move. Boom. Okay, cut. All right, this last one is for the PA axial knee. We'll be using the Coventry method, also known as the tunnel. Again, the SID is 40 to 48 inches. The patient's position is prone. Position of the part is the patient's knee flexed 40 to 50 degrees. I check with a protractor. Foot resting on support. You center the upper half of the IR to the knee joint. Upper half of the knee joint to the IR. The angulation projects the joint to the center of the IR. You also want to make sure that there is no rotation of the knee. I've double checked, there isn't. The CR is perpendicular to the long axis of the lower leg and centered to the knee joint, right here, over the popliteal depression. You angle the tube 40 degrees when the knee is angled 40 degrees. You angle the tube 50 degrees when the knee is angled 50 degrees. They are both the same. And again, I'm going to be giving the technique of a regular AP knee at 65 and 5. Again, shielding the patient as much as possible. And we're ready to take the image. Don't move. And now that we've taken all 7 images for this patient, the 2 of the chest and the 5 of the knee, we take all 7 of our IPs and we go back to the computer workstation. Bring up the study you were in. And with all 7, I only have 1 for purposes of brevity, but for all 7, you select the procedure you took. You take the barcode and scan it to electronically link them, and then you run the cassette. Then the image will come up, all 7 will go up there, and then you'll do your PAX and Meditech thing. All right. Filming? All right. Okay, the film critiques for a good PA chest. After you bring the image up on the computer, you want to be able to see the entire lung field, apices to the costophrenic angles. You also want to make sure there's no rotation. You can check that by looking at the vertebral process. Make sure the sternal ends of the clavicles are each equidistant from the processes of the vertebra. You want the scapula both out of the lung fields. You want to be able to see 8 to 10 ribs, and you want to be able to see the spine through the heart shadow. For the lateral chest, you want to be able to see good superimposition of the posterior ribs. You want the arms out of the lung fields, no rotation of the sternum. You want to be able to see the entire lung fields, apices to costophrenic angles. And you want open thoracic vertebra spaces and intervertebral foramina. And you also want the hilum region roughly in the center of the radiograph. For the AP knee, you want open femorotibial joint space with interspaces of equal width on both sides if the knee is normal. You want the patella superimposed on the femur. No rotation of the femur. You want the femoral condyles to be roughly symmetric. And you also want no rotation of the tibia. You want the intercondylar eminence centered. And you want a slight superimposition of the tibia head on the distal fibula. I'm sorry, the fibular head. Yeah. You want the head of the fibula and the proximal tibia to have slight superimposition. You also want to be able to see some soft tissue around the knee joint and the bony details surrounding the patella on the distal femur. For the medial oblique knee, you want the proximal articulation of the tibia and the fibula. You want there to be separation. This could be a little bit better. You also want to see the posterior tibia, and you want the lateral condyles of the femur and the tibia, nice open joint space, and you want the margin of the patella slightly beyond the medial side of the femoral condyle. For the lateral knee, you want the patella in lateral profile, open patellofemoral space. You want the fibula head and the tibia slightly superimposed. And you want the femoral condyles with proper density. You'd also like to see these superimposed a little bit better. For the setagast, you want the patella in profile. You want an open patellofemoral articulation. You want to see the surfaces of the femoral condyles. You also want to see the soft tissue of the patellofemoral articulation. And you also want to see the bony detail on the patella and the femoral condyles. For the PA axial knee, Camp Coventry, also known as a tunnel, you want a nice open fossa. You also want to see the posterior-inferior surface of the femoral condyles. You want the intercondylar eminence centered in open femorotibial joint space. The apex of patella not superimposing the fossa. That's clear. And you want no rotation. You should see slight tibiofibular overlap. That's a little bit more than that. You also want to see the soft tissue in the fossa and the interspaces. You can see a little bit there. You also want to see the bony detail around the intercondylar eminence, the distal femur, and the proximal tibia.